All right, well, good morning from Ortona South Campground in Moorhaven, Florida. It's 74 degrees right now. It's 9:45 in the morning, and it's going to be 86 by the time of kickoff for the Army-Navy game this afternoon. So I'm very, very excited about that. This will be the second year in a row I've watched Army-Navy from Ortona South. Anyways, this is chapter 40 for the AEMT book. It's spine injuries. A little bit of a disclaimer here. This is a national-based program. Excuse me. In the state of New Hampshire, we are a lot different in our protocols in that we do not backboard people anymore for spinal immobilization. We have spinal motion restriction, which says that putting people on a backboard is actually detrimental to them. That people on backboards tend to wiggle and squiggle a little bit because backboards hurt and they're uncomfortable. And all we're immobilizing are the big muscle groups. The spine is manipulated far more by the small muscles that are within your torso. So by maintaining cervical immobilization or manual cervical stabilization, a cervical collar, and then putting them on a stretcher, flat, if possible, they do better, and there are no negative outcomes. This chapter talks about collaring people, which is good. It then goes into using seated spinal immobilization, KED boards, the green Kendrick extrication devices, and also talks about standing takedowns for longboarding and all the process of longboarding. You guys all need to know how this works. You may work in a state sometime where you have to do this. And the AEMTs, you have to take the practical exam. And the practical exam currently, 2021, still consists of shortboarding, longboarding as options. So we're going to go through all this. I think the EMT book and the AEMT book both do a few things better. The EMT book addresses a few things a lot better than this one does, and vice versa. So this is the AEMT book, AEMT chapter 40. It's 120 slides, but keep in mind that we're going to kind of scoot through a bunch of them once I kind of explain what we're doing with those slides. Okay, so I'm going to turn my camera off, and then we will go into my chapter 40. If I can get it to come on. There we go. Excuse me. Different things are blooming down here. My allergies are bothering me a little bit. All right. So, spinal injuries. So, the ages of 16 to 35, especially males, because we do stupid stuff like, oh, hold my beer, watch this, or I'm going to show off for the girl across the parking lot, and I'm going to do a wheelie on my motorcycle. All right. So, high-risk activities, car accidents certainly, or motor vehicle crashes, cars, motorcycles, falls, penetrating injuries, like gunshot wounds, knifings, okay, and then sports injuries, football, and this, these are males and females, don't get me wrong, football, rugby, soccer, lacrosse, bicycling, hiking, climbing, and cord injuries certainly are devastating. Not always do we have permanent disability, and not always, are we paralyzed, because there are actually 3 segments to a spinal cord. If you sever the whole cord, then you have everything forever. But you could damage one of these chambers within the cord and have, for example, no movement but sensation, or sensation but no movement but no sensation, sensation but no movement. Get that tongue twister. Okay, so when we see that mechanism of injury, which is that potential, then we want to, you know, like in our practical station trauma assessment, I'm gonna have my partner hold C-spine. Anytime you see that potential mechanism, the first thing you do, hold C-spine, check ABCs, okay? In the state of New Hampshire, like I said, we're allowed not to backboard people. We don't backboard people. We're also allowed to make the decision not to collar them and do spinal motion restriction based on an assessment of them. However, the first piece of that is manual stabilization of the C-spine. Do all of our assessment and then decide whether we want to collar them and immobilize them or not, okay? Cervical spine is delicate. It's no more, it's a little bit thinner than like when you get down into the thoracic spine. But the reason I think of it as more delicate is, and prone to injury, is that there's a lot less musculature supporting it and protecting it, right? When you think about your pectorals, your chest muscles, your back muscles, your lats on your sides, right? All of that goes into, and ribs, and all that goes into helping protect the spine. But we've got a 20 to 25 pound weight sitting on the top of our cervical spine with very little stabilization and very little support and protection. Okay? Now, how do we decide what the risk factors are besides a good mechanism of injury? Any head, any facial injuries, we got to start thinking C-spine. So anything from the clavicles up, all right? So north of the collarbones. If you've got a GCS less than 14, remember GCS measures mental facilities, mental faculties rather, and that means your brain. So if your brain is struggling with something and there was trauma involved, you got to think about cervical spine. So just a little review, one of the diagrams that I think we've seen before, our central nervous system and our peripheral. So our central nervous system is the brain and spinal cord. The peripheral nervous system is everything that comes off of that, okay? And you can see these create what are called dermatomes. So let's say we're down here and, let me see, 5, 3, 4, 5. So let's say we're down here somewhere around T8 to T10. If you sever that nerve, okay, you will have, or the cord at that point, then you will have nothing from there down, okay? So a dermatome would say that, oh, at T8, it's somewhere in this area. I know I don't have it exact, but let's say at T8, you lose the diaphragm, okay? So, or the level of the diaphragm. You actually lose the diaphragm up at C2, okay? So C3, 4, and 5 keeps the diaphragm alive, okay? So if you injure C2, you lose the diaphragm. But for everything else, sensation-wise, movement-wise, you know, somewhere around here, which is where the diaphragm is, you're going to lose everything from there down. So I said C3, 4, and 5 keeps the diaphragm alive. You have a cervical spine injury and your patient is breathing adequately on their own but cannot move their arms and legs. It's somewhere below C2, okay? If they can't move their arms and legs and they're having trouble breathing, gasping for breath, or not breathing, right? Then that's above C2. All right, so central nervous system and peripheral communicate with each other. Oh, that makes sense. And we have this tracks of gray and white matter that allow these signals to go up and down between my big toe and my brain. If the cord's severed, everything stops. Again, central nervous system, brain, cord, peripheral, all the tissues outside of that. Now we have efferent and afferent neurons. Now neurons, remember, are the cells in the nervous system. So we have motor neurons, efferent. They go out to the body, out to my big toe, and say, all right, I want you to move. Okay, I want you to rub the toe next to it because it itches. Okay, efferents are those sensory nerves that come back to my brain going, oh yeah, that's better. Whew, okay. Efferent are divided into autonomic and voluntary. Now, the autonomic nervous system, we've talked a lot about this. Sympathetic, parasympathetic divisions, right? Sympathetic, fight or flight. And that is your renals, your epinephrines, norepinephrines, dopamines, all of those chemicals, some of the steroids that are responsible to make your heart beat faster. Your bronchioles dilate so you can bring in more oxygen with each ventilation. Increases your respiratory rate so that you can run away faster than you've ever run, or you can have battle royale and fight to the death right there. Okay? Now that is a healthy scenario internally and chemically for short periods of time. However, the longer you're in it, the more of a toll it takes on your body. So we have the parasympathetic nervous system, which brings it back into line, slows everything down, right? One of the nicknames for that's feed or breed. And feed or breed meaning cells, right? We need to replenish the glucose and oxygen in the cells. We need to repair and replace any tissue that got damaged. When we have a disruption in the signals, either the sensory is affected or the motor is affected or both. And nerves do not regenerate. Injury is permanent. So our spinal column, good little trivial thing here. C1 and C2. C1 is called the axis and the atlas. I'm sorry, C1 is the atlas and C2 is the axis. So everything revolves around the axis. C1 connects your brain, your skull, I should say, I'm sorry, at the foramen magnum, the big opening out of your skull. C1 is mounted there. So your skull rotates on an axis, which is C2. Now, C2 has a little pivot point that sticks out of the top of it that everything kind of rotates around. And that's kind of the weak spot in this whole system. I remember my EMT course and my instructor chanting at us, 7, 12, 5, 5, 4, 7, 12, 5, 5, 4, 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccyx. And the coccyx is your tailbone. Now within this, foramen is opening or passageway. So I said the foramen foramen magnum is the opening out of the skull. Each of our vertebrae also have spinal foramen, okay, for the spinal cord to pass through. When these areas get damaged or chips get blown into that canal, that's when we end up having nerve damage. Now, these are our discs and vertebral bodies. The discs sit in between them. So you can damage these, and as long as the ligaments that hold them in place stay connected, then you don't have any cord damage. When I was 18, I broke my neck in 5 places. The spinous process, I broke 1 or 2 of those in my neck. I crunched the vertebral bodies on 2 of them, both uppers and lowers. And here through what really concerned them the most. Well, this concerned them a lot, the spinous process and the bodies, because of the the concern for ligamental damage. But I also had some linear fractures here. And so, of course, that was a big concern at the time. All right, so 33 vertebrae total, 712, 554. They have this disc in between. That disc acts as a little bit of a cushion, okay? When a lot of people have back pain or neck pain, like chronic neck and back pain, they've had an injury to that disc, and that disc is bulging. And when it bulges, it pushes in against it causes pressure on the cord and hurts. And that's why, you know, sometimes you'll get these folks with this chronic pain who have shooting pains down their arms and legs, or numbness and tingling in an arm or a leg, and it's all because of the disc pushing on the cord. So 5 regions, as we've said: cervical, thoracic, lumbar. The sacral spine makes up the back wall of your pelvis, and then your tailbone. Now, the spinal cord itself ends here in this at the top, bottom of the lumbar, top of the sacral, and it comes out into what they call horse's tail. So instead of having one solid cord with nerves coming out of it, they all separate out and look like all the hairs in a horse's tail. So if you break your sacral spine, you're not going to be paralyzed. Coccyx has no nerves coming out of it, and so although the tissue around it, you get a lot of pain, you don't get any sort of neurological problems with coccyx. 712.5, sacral coccyx, again, inferior region. Now, half of injuries, this slide says half are in the cervical spine. That number's high from a lot of stuff I've read, but cervical spine and lumbar spine are the most injured. Cervical spine makes sense. You got a 25-pound weight sitting on the top of it. And lumbar makes sense also when you think about the fact that roughly half your weight is sitting on L4, L5, and it's a pivot point. So everything you do puts pressure on those vertebrae, and it's not as well supported as your chest is. And the more weight you have, think about being overweight. You know, we have different body shapes for overweight, but if you think about, you know, kind of the typical guy, you know, the big gut, that weight from the stomach pulls forward against the spine and causes a lot of pain, causes unnatural extension of the angle of the lumbar spine, and it stresses the muscles and ligaments, and it's awful. Okay, so chronic back pain just from being overweight, lumbar spine. But again, pivoting, twisting, landing on things, jumping, falling, a lot of lumbar spine injuries also. My experience is that the thoracic spine injuries tend to be a result of direct impact as opposed to indirect. Okay. Cervical spine, again, the weight of the head. We have flexion where we bring our chin down to our chest. We have extension where we bring our head straight back and look up at the beautiful blue sky and wispy thin white clouds that I'm looking at in the palm trees. And then rotation left, rotation right. Those are all normal movements. But when you have movement that stops suddenly, or you're stopped and you have sudden movement, like you're sitting at a red light and you get rear-ended and bam, your head whips back and you hyperextend. And then when you hit the seat back, bam, you bounce forward and you hyperflex, okay? Whiplash injury. But it causes stretching in the ligaments and it can be devastating and long-lasting. But ligamental stretching, as well as discs and those spinous processes, that's what happened to me. My head was sideways when we hit the trees, and my head went back and forth, back and forth, back and forth, and that's how I ended up with my cervical injuries. Now the cord, the base of the brainstem goes down through that the foramen of each vertebrae, all the way down to L2, and then separates out into that horse's tail. Now, we have nerve roots for each spot where a nerve comes out of the spinal cord. We have nerve roots. So if you think about your fourth rib, fourth intercostal space, below each rib we have a artery, vein, and a nerve that run along that. Okay, the nerves off of your spinal cord, there's a left side and a right side. It's not a complete circle. So think of, and this nerve root, think about shingles. Shingles is a virus that attaches to your nerve root of a nerve somewhere in your body and will then affect that nerve when it flares up. So it could be, oh, I'm having left-sided chest pain. Well, it's just along that rib, and you're going to see things that go with that rib. Okay, so that kind of shows a nerve root and how that nerve comes out and gets utilized. Again, kind of redundant messages out, motor senses out, sensory back. Everything, whether it's function or sensation, results from a nerve impulse. Now the phrenic nerves to the diaphragm, high cervical, again, C1, C2. So you damage C1, C2, you have everything below that, right? So do you have intercostals? No. Do you have diaphragm? No, you're not going to breathe. Okay. If you damage C3, 4, or 5, you may not have intercostals, but your diaphragm will continue to work and you will continue to breathe. You've lost your intercostal muscle, so it won't be as effective. But the diaphragm is the primary muscle of ventilation. So think about my diaphragm, and I've talked about, you know, having my diaphragm damaged somehow during my gallbladder surgery. The two halves of the diaphragm don't work together correctly. So initially when this happened, I was relying primarily on my intercostals. And when I laid down flat for more than, like a second, I couldn't breathe. I had trouble breathing. So the diaphragm is that important to this. Now, whatever the damage to my diaphragm was, it's gotten stronger. It still doesn't work real well together, but it's gotten much stronger on both sides. You know, my body's compensated for it, and I do okay now. But that's how important the diaphragm is to you. Now, a reflex is kind of a safety net for us. I want you to think about going out in your kitchen and sticking your hand on a hot burner. Now, we know that if you pick up, like my coffee cup right now, I take a sip. That maneuver was fairly quick. I want to take a sip of coffee. The message got down to my arm, reach down, grab the coffee cup, pull it up, take a drink. That's really quick, but that 1 to 2 seconds would be devastating to your hand on that hot burner. So that sensation gets picked up in your hand and is reflexive in that that nerve impulse only travels up basically into your forearm, and then the message goes out, pull, 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 and you pull your hand away. Okay. If you've ever, hopefully you've all had physicals at some point and the doctors checked reflexes. One of the places they hit with their little, either with their fingers or their little reflex hammer, is up in your forearm to see if your hand jerks. Okay. Your knees, right, just under your patella, underneath your kneecap, they'll tap that to see if your foot jerks. Those are all reflexive actions, and the better your reflexes are, the less damage you receive when you do something stupid like put your hand on the stove, because Kevin told me to. Sensations away. So like I said, a lot of these slides are very kind of redundant, but I've left a lot of them in, hoping that it'll help plant the seed in your brain. So ascending, the impulse is back, sensations. Descending away, carry motor, but also control activity and tone, which is part of motor. So ascending, motor activity, right, gets divided up further. There's a difference between light touch, where you can pick up a screw, a little screw to fix your glasses with, and gross motor, where you open a car door. Okay. Pressure, light pressure, heavy pressure, pain, temperature, and vibration. Now remember I said there are three compartments, I guess, in your spinal cord. And I said you might be able to move but not feel, or feel but not move. You might be able to feel pressure but not, so heavy pressure. Like if somebody rolled over your foot, or you rolled over your own foot in your wheelchair, you'd feel that, but you wouldn't necessarily feel your wife putting her hand on your arm. Okay, so there are various tracks that carry nerves, and you can have partial cord injuries, which, depending on where it is, affects those different things. Temperature. I mean, you're sitting in your powered wheelchair outside at a campsite with your family, and you receive a burn to your foot because you were a little close to the campfire, but you didn't realize it, right? Yeah. Not all column injuries have cord injuries. Mine is the ideal example of that. I got a CAT scan. They freaked out when they saw the fractures, right? Got a CAT scan. I got put in extended collars. There was talk about going in and cutting me open and putting screws and rods in my neck. And thank God my neurosurgeon went, oh, whoa, let's look at this a little deep. Let's sit on him for a few days. Kevin, we're going to put this collar on you. And the collar was extended all the way down to my waist. It was an extended Philadelphia collar. And he said, you're going to be in bed, period, in the hospital. 3 days from now, we're going to reevaluate. And, more scans and whatnot. And we treated it that way. So never once had neurodeficits with it. So this is one of those national statements. Immobilize the spine so movement does not make it worse. All of the studies have proven, this is one area where EMS, the national EMS, especially educators, are so far behind, that the studies that were done in the ERs back in the late 90s, and that have then created follow-up studies, have all shown that if you have an injury, you have an injury. We're not going to make it worse by moving you. If you don't have an injury, we're not going to cause one by moving you. Okay, so that's why, like in New Hampshire, oh, and if we move you, there is more movement of the spine than if you move yourself. So by yanking and pulling on people to get them out of a car, we are manipulating their spinal cord and their spinal column far more than they do if they turn, put their legs on the ground, stand up, turn, sit down, and then lay down on our stretcher. That is less traumatic for them than us yarding them out of a car by grabbing onto things, okay? So, but immobilize so that if you see on a registry exam, we immobilize all patients. Mechanisms of injury to the spine, right? Anything and everything. Motor vehicle, pedestrian, bicycles, sports, assaults. So column injury versus cord injury. Column is the physical structures around the cord, the vertebrae, whether it be the bodies, the discs, the spinous processes, okay? Cord injury itself is the cord. The cord will give you the neurological symptoms. Shearing of the cord, you lose it, everything. Now, in order to shear the cord, generally speaking, I want you to take both fists, both hands, make two fists, and set them on top of each other, like vertebrae would be. Now I want you to take your left hand and yank to the left, and the right hand and yank to the right. And that's what you get with a shearing injury. You pretty much get that with the column as well. And you can feel that when you come down a neck. You palpate a neck or a back, and you feel what we call a step off, where there is a step. I mean, you're coming down and you should feel bump, 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 right? Because that's what you're feeling in the back of the spine. You feel bump, 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 shelf, or bump, 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 overhang, step off, okay? Pretty much at that point, you know they're not gonna have any movement from there down. And if it's in the neck and it's a motor vehicle accident, pretty much you're assessing a dead person anyways. Now, we can also have secondary injuries. Secondary injuries are the swellings, the ischemic events. So you've damaged a blood vessel feeding the cord, and we have lack of oxygen, and we have ischemia. We can also have bone or bone chips that move in, like with the disc injuries, okay? Concussion, whether it's spinal cord or whether it's brain, concussion is kind of the same thing in that there's another thing I want you to do. Take your non-dominant hand, in my case, it's my left hand, and I'm going to take my right fist and I'm going to punch it as hard as I can. All right, I look at my hand, I look at the brain, or I look at the spinal cord, and I look at it and I go, it hurts. I've got some kind of numbness and tingling in that hand. I got some kind of zinging electrical kind of feeling going on with it, but I don't have any swelling, I don't have any bleeding, I don't have any fractures. That is a concussion. That's exactly the same thing that your brain and cord get symptom-wise when there was no structural damage, but it took a blow. Okay, so you get that temporary disruption of function. Total disruption, total loss. You will also get swelling that occurs, which can affect further up the cord as well. This says you can't fully determine the extent of the injury for 24 hours. Complete ones, you absolutely can. You know, they're not moving anything, and they do a CAT scan, and it's severed. Other things will evolve, though. Keep in mind, Remember, we just talked about the sympathetic, parasympathetic nervous system. You lose that distally. How is their body going to adapt? How is it going to function when it loses the ability to vasoconstrict? Right? Are they going to be shocky or not? So that is things that do kind of evolve over the next several days. You can have an incomplete. Again, what part of the cord did it break? Did it damage? I'm sorry. And those certainly we may not know, because some of those injuries mimic other injuries, like the cord concussion, cord shock versus permanent damage. So as swelling goes down, also when you've got swelling in that cord and you've got neurological symptoms, until that swelling goes down, we don't know what's going to be permanent or not. Everything may come back and nothing may come back. So I was talking about three segments. Interior, central cord, we've got anterior cord, and then we've got the sides, the halves. So Brown-Séquard would be, so I'm sorry, there are three, there's four, I mean, there's, anyways, inner, left, and right, but they also will break it down to anterior, now, anterior tend to be bone fragments or vessels. Loss of motor function, loss of pain, temperature, and light touch below that level. However, you keep vibration and position senses, so you know where your foot is. You just can't move it. You know where your foot is, like, shit, my sock's on fire. You know, I'm at the campsite, my sock's on fire, but I can't move it, okay? Central cord, hyperextension of the cervical spine. Weak upper extremities while the lowers remain the same. Sensory changes can be anything though, okay? Brown-Séquard, penetrating, which causes hemitransection, which means severing one half of the cord on one side or the other. You get loss of motor and vibration and position on that side with loss of pain and temperature on the other side. This is the one that freaks me out when I think about it, because I mean, I'd always been taught it's all or none. You get that injury here and you lose motor and on that side of the body, but over here you lose, right, temperature and pain. Wow, which means that on the side that you can't move, you can feel pain. So great, my sock's on fire, my foot is on fire. Oh my God, this freaking hurts, but you can't move it. That's awesome. So spinal shock is another word for cord concussion. And again, you punch your fist, right? That is cord concussion, cord shock. The problem with that is you can sometimes have a lot of swelling with it after the fact, okay? We lose that ability to control vasculature, hypotension, right? Neurogenic hypotension, neurogenic shock. If you have a patient with that neurogenic aspect to it, and they have any form of hypovolemia at all, they become extremely hypotensive, okay? So our neurogenic versus hypovolemic. Remember, one of the one of the terms that we use for neurogenic shock is warm shock, because they stay mostly pink, warm, and dry, whereas hypovolemic, they become pale, cool, and diaphoretic. Heart rates remain basically the same in your neurogenic shock patient, whereas in the hypovolemic, they get tachycardic. So I had a motorcycle accident one night. Guy paralyzed from the belly button down, would not let us cut his leather jacket off. You know, you can't move your legs, but you're worried about your coat. And he wasn't like a gang member or anything either. Just, you know, it was a jacket. He was kind of in denial about this whole situation. It was a cold night near Halloween, and so we didn't want to take his coat off because we were afraid of moving him because we didn't know any better back then. And so I didn't get a blood pressure on the side of the road. What I got was a pulse of 80-ish, if I remember correctly. It was a normal pulse, and he was dry, warm, and pink. And we get in the back of the truck, and I did a palpated blood pressure, and it was like 60 or 70 systolic, you know. And at which point I basically gave him no choice. I said, "You're going to die. I'm cutting your coat off." Neurogenic shock. So it tricked me because I just said that to him on the side of the road, you know, out in the field rather. You know, I'd have just said fuck it and cut his coat off him and let him yell at me. But it was certainly a lesson to me. You know, mechanism of injury, neurogenic symptoms like paralysis, you got to assume they're shocky. Don't go by skin. Don't go by pulse. Even without hypovolemia, this dude had no bleeding at all, and he was tanked. Okay. Normally, the body can respond fairly well, but with this spinal cord injury, we lose, depending on where it is, of course, we lose the epi and norepi into the bloodstream, so we lose that fight or flight. So, scene safety, what's the mechanism of injury? How many patients do I have? Oh, motorcycle accident. He hit a guide wire holding a phone pole up. He's laying 50 feet away in the field. High index of suspicion, okay? Walk up to him. Hey, how you doing? My name's Kevin. What's your name? My fucking back hurts. Okay. His airway's open. He's ventilating fine because he's saying full sentences without any distress. And, oh, he's got good radial pulse. Hey, squeeze my fingers for me. Squeeze my fingers. Wiggle your toes. Nothing. Okay. So I've done A, B, C's, and D's right there in the first 7 or 8 seconds, and I know he's screwed. Okay. And he actually, being a typical guy, he wanted to know how his bike was. His back hurts. Can't move his legs. He's not perfusing. How's my bike? Typical guy. Okay. So look for things that will tell you what you might see, right? Windshields, helmets. Did he have a helmet on? Did he not have a helmet on, right? We live in New Hampshire. Helmets are not mandated. So you got the guys coming in from Mass and Maine where they are, and their helmets are strapped to the back of the bike, right? If they were wearing the helmet, and we'll talk about some helmet removal later, where's the impact on the helmet? Okay. So cars, bikes, motorcycles, falls, blunt trauma, you know, the ass beating, as well as falls, right, causing blunt trauma, penetrating. Now, it used to be when I was younger, anybody who got shot in the torso always got backboarded because, you know, the path of the bullet, that big cone of damage could have disrupted the spinal cord. Nope, it doesn't. So if point A, the entry wound, and point B, the exit wound, line up, and the spine is not between them, you don't have to collar and board them, okay? Sports injuries, hanging, certainly. Diving accidents, right? Hold my beer, watch this, and off the rock you go into the shallow pool of water, or into the shallow gene pool, as I like to think of it. Any unresponsive trauma patient, you have to assume cervical spine. So manual stabilization, it's a great picture of it. You guys have been doing it with your assessments. The other job for this guy is to talk to the patient. All right, you're going to ask questions. You're going to, hey, does this hurt? Does this hurt? Hey, can you squeeze my fingers? Hey, can you move your feet? Right. But his job is to look at this patient and go, hey, my name's Kevin. What do you like to be called? All right, so this is what we're going to do, right? I don't want you to move your head or neck. I don't want you to move your back. I want you to just kind of hold still while we do this assessment. Let us know if anything hurts, and just explain what's going on. If you just sit there and stare at her, it's a scary enough situation without having everybody look like they're ignoring you, okay? Hold C-spine until you call it, board them, or decide you don't need to board them, okay? You got the guy who came off a step ladder from 7 or 8 or 10 feet up, and he's got a busted ankle that's obviously broken. You still need to hold C-spine, right? I get done with my assessment, and I look at you and go, it's an isolated leg injury. The neck's fine, the back's fine. You can let go. We can sit him up, okay? So at that point, you can let go. If they are walking around the scene, have them stop, come around behind them, and hold C-spine. And again, talk to them. We still need to do ABCs. Lying on the ground, jaw thrust if you need to, right? Because if we're holding C-spine and we're not sure what's going on yet, ideally you do jaw thrust. Now, you can see here why this person can do jaw thrust so easily, right? Because the fingers are already here at the lower angle, or at the angle of the jaw. So you can just slide those 2 fingers up here, right here, and just lift straight up with the jaw. Now, things to take into account on your index of suspicion, right? Mental status. Do they have any altered mental status? Intoxication, especially drugs and alcohol. Think about what narcotics, think about what we use narcotics for in medicine, right? We use narcotics to decrease pain. So if they are on narcotics, whether it be heroin, fentanyl, carfentanil, whatever, and they've been in a car accident, guess what? They might not feel the pain, because I'm going to give them fentanyl for their neck pain to make it better, and they already took far more fentanyl than I would have given them. So they're already pre-medicated. Which I guess if I was going to get in a car accident and break something, I'd rather be pre-medicated myself. But so shock, again, if they're not perfusing their brain well, they may not have that whole sensory thing going on. Do our secondary assessment while we're holding C-spine, right? Our head to toe. If you've got a good mechanism of injury, do the head to toe rapid trauma exam, okay? Every time you get to the end of a limb, hands and feet, CSMs. Persistent priapism, or priapism persistent. Remember, if you roll your car over in a ditch, that should not excite you. Just saying, you should not have this. Now, maybe it was there before, right? Maybe they just took a Viagra and they're whatever, right? I had a trauma patient who had priapism, who had a spinal cord injury, had a spine injury, but it turns out that he was diabetic and had what's called a penile pump. So that activated during this. It's like a little air chamber that gets inserted into the shaft, and there's a little, like in his leg under the skin, there's like a little air pump that you push, 6, 8, 10, whatever times, and boom, 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 up it goes like an erector set. Well, that apparently somehow got activated and during this event. So I was wrong. It was not priapism because of his spinal cord, but it certainly fit with that injury pattern, okay? So when you are assessing CSMs, I don't necessarily do this during my rapid trauma exam, but after I'm done with that, I've identified life threats, I come back into my detailed exam, then at this point, hey, I want you to pull. I want you to, like flex, make a muscle, and I will pull on that arm, that hand, to see if they have good strength. push against it. I do this when I do CSMs. I do this with the hands and feet. I don't do it with the elbows and knees though, but during my detailed I will. Now this is called abduction. How is their strength at taking their fingers away from their body, right? If you are abducted at an ATM, that means somebody took you away. So have them hold their fingers apart, and then you try to squeeze them together. And I do this at the same time with both hands. Obviously, I don't hold the wrist because I don't have 4 arms, but I have them hold their hands out straight in front of them, spread their fingers out, and then I try to squeeze, and I'm looking for equal strength from the left side to the right side. This is adduction. Can they hold their fingers together? And I will squeeze, I'll hold and see if they can spread their fingers open. Now, can they flex? So, and extend. So right now, we're trying to get them to extend their hand back, having them extend their, flex their foot back, having them extend their foot, and then we're looking for sharp or dull. Now, all these people like to show using this long Q-tip, you know, on the wood end versus the Q-tip end. That's all great and everything, but we really don't carry these things in the ambulances anymore. So a pen and a fingertip work perfect. Remember I mentioned earlier dermatomes. So you think like, let's say, oh, T8, everything from T8 down. Well, when you get down into the L's and S's, you have like especially the sacral nerves. Remember the cord ends, but all the nerves come out. S4 and S5 are kind of a good example of this. And I don't remember exactly which is which, but one of them comes around the inside of the leg, so like covers the front of the leg and then comes down to the inside of the ankle, and the other one comes up just the inside. Anyways, so it's almost like it splits the leg in half lengthwise. So I was doing sharp or dull, and I was kind of going back and forth on the foot, not thinking about it, and the guy was like, oh, I don't know. Oh, that's sharp. Oh, I don't know. Maybe that's dull. And so and he was being kind of an uncooperative gentleman, and he was a motorcycle accident. And so I started using an 18 gauge needle because I thought he was pulling my leg. I thought he was just being anyways. And sharp or dull, dull, sharp or dull, dull, sharp or dull. I got all the way up to the middle of his thigh, and I had about 8 or 10 little holes that were oozing blood. And then I hit a spot, and he went, ow! And I went back down the leg, and I did it on the inside of the leg or the outside, whichever side of it. And ow, 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 ow. Boom, S4, S5. Okay, so it's not simply up and down. When you get below the waist, it can be in or out. That can be different. Okay, so oh, there's the big Q-tip. All right, sharp or dull. Sharp or dull. Flex your big toe. Yeah, okay. Wiggle your toes for me. I'm more impressed with that. Now, management, depending on whether they're sitting, standing, or lying down, depends on how we manage them, as well as whether they're stable or unstable. We're going to put an appropriately sized collar on. This section I left in here just to declare bullshit on it. If you want to figure this out this way, have at it. Have at it. I've never seen anybody do it but in books. You know, how many fingers on the side of the neck does it take versus how many? You know what? I want you to think about this. Oh, by the hang on, right there. Okay, we have cervical collars that are either adjustable or not. Most of them now are adjustable. I start at no neck. So you see these holes on the side. Right? The shortest, that hole gives us the shortest collar. That's called no neck. If you use the no neck, don't take offense. Obviously, she has a neck, right? But what I do is I start at no neck, because my experience is about 90% of all patients have a no neck size neck. And I put it all the way down and I put it under their chin and go, yep, it fits. And then I push these little tabs to click it and stabilize it. If it's short, then I go up 1. This is just, why would you use your fingers on the collar when you can use their neck to size the collar for their neck? Okay, so and then it wraps around the back, and we have Velcro here that attaches to Velcro built into the plastic. Okay, you notice he's still holding C-spine, because until we are on National Registry, until we're on the stretcher on a backboard, or in the state of New Hampshire, until we're just on the stretcher, we're going to hold cervical spine. All right, now maintain until patient's completely secured to long board. A long board is a splint, just like a SAM splint is a splint. So CSMs, before you splint them, size up the splint, place the splint, secure the splint, double check the splint, and then check CSMs, okay? Now, when we assess our patients, all right, and we're going to go over this face-to-face. There's a spinal assessment part of our protocol in New Hampshire for this, and it's actually a very good assessment. But once you decide whether you do or don't, it's based on protocol, but you need to document why you didn't board somebody or why you didn't collar somebody. Patient had a positive mechanism of injury, motor vehicle accident, blah, 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 neck pain on the sides, no pain over the spine itself, no neurological deficits, the spinal assessment was negative, patient was allowed to sit up on the stretcher without a collar, okay? Any altered mental status, though, you got to do, in a trauma patient, you have to do spinal restriction, motion restriction. Okay, so assess your patient based on mechanism of injury and their signs and symptoms. Figure out their level of consciousness. Ask them if their neck or back hurts. Now, we're talking spinal injuries. We're not talking muscular injuries. So if they say, yeah, my back hurts, where? Point to it for me. And if it's in the middle, over their spine, okay, that's a point against them. But if it's on the side, it's lower left back, it's the right side of their neck, okay, that's not going to be spinal column, right? Then you run your hand down their spine. Start at the base of the skull and run your finger right down the cervical spine, thoracic spine, lumbar spine, all the way to their pelvis, okay? And push on the vertebrae as you run your fingers over them. And if they don't hurt and the pain is to the side, they do not have a cord or column injury, okay? I've mentioned the ER studies. It's called Nexus, N-E-X-U-S or N-E-X-X-U-S. Anyways, in the United States in the late 90s, there were hundreds of emergency rooms involved in this study, and thousands of ER docs and hundreds of thousands of patients. And they did this assessment. Do you have pain? Is it over the spine? Do you have tenderness when I palpate the spine? Do you have numbness or tingling any place? Do you have equal strength on both sides? Can you tuck your chin to your chest as a last motion? And if the answer to all those is good, appropriate, no pain, no paresthesias, good grip strength, all that stuff, then when they x-rayed them, they did not find any injuries on any of those patients, okay? So any of them had pain over the spine, okay? Well, it backs it up. So spinal, not back, not neck, right? Is it over the spine? palpate the spine. Does it hurt when I touch, right? If there's tenderness or there's pain, then yeah, you immobilize. CSMs. If you've got some deficits with sensory or motor, we immobilize them. Now, a distracting injury. You have a broken forearm and it's flopping in the breeze and its pain is 9 out of 10. That pain may be worse than the 4 out of 10 that you would have had in your back. Okay, so that's considered distracting injury. Okay, it could also be a distracting injury to somebody else, like you're a parent and your child has a floppy forearm. You may not be as attentive to your own physical needs as you are to hers. Okay. Once you suspect spinal injury, we stabilize them, and what I mean by once you suspect, you walk up to them, they've got mechanism of injury, we're going to suspect it. Boom, stabilization. Then afterwards, if we don't need it, we can let go. Somebody who's lying on the ground, we want them on their back on a backboard. Okay, so if they're supine on the ground, we're going to log roll them up, look at their back, slide a board under them, roll them onto it. If they're face down, do one movement. Okay, don't log roll them to assess them, then log roll them to look at their back and put them on a board. Just put the board behind them, look at their back, log roll them onto the board or scoop. Okay, and then go from there. Now, in a registry environment where we're going to use a long board to fully immobilize them, the head gets attached to the board last because you want the head to be able to move with the torso. If you have to move the torso a little to get it onto the board better, you want the head and neck to follow in line. Okay, so what I always teach with backboarding is torso, hips, pelvis, torso, pelvis and hips, legs, arms, head. So torso, legs, head. All right. Arms get done after just because they're not going to move the head and neck. So torso, legs, head, and arms. All right. So, and what I mean by immobilizing the arms is just if they're altered, just a cravat to hold their hands on top of them, because you don't want to be carrying somebody to the stretcher and trip over their hand or step on their hand. So put the collar on. We've got good immobilization taking place. We bring the splint down and make sure it's the appropriate size, right? So if you're using a scoop, you might have to extend it out some. We've got a towel here for padding. These are head block pads. So once this patient's on this board, right, we're going to use head blocks to secure the head and neck. Okay, using plenty of help, we're going to log roll them. Remember, we want their spine to turn in one long line. So we've got person at the head, we've got somebody at the, and this is the way I like to do it. I like to interlock my arms so that I'm not pulling, he's not pulling, he's not pulling, and we have 3 pivot points. The pivot points overlap. So shoulder, hips, belly, knee, thighs, ankles. We roll them up. Somebody else slides a board in underneath them. And then we log roll down onto it. Now, to do this, the person at the head counts 1, 2, 3, so that he's anticipating the move, not catching up after the fact. Right, now, you can see his torso's done. She's doing the hands first, whatever. And then head blocks. So these blocks go on each side of the head and help hold the head in place. And then you've got some straps here over the chin and over the forehead. I don't like this. If they're unresponsive, I like this. I don't like to strap people's hands down if they're awake and not, like combative, but because they get claustrophobic with it. So we've got a chest strap and a hip pelvic strap. I'm going to show you a better way to do this, and that's crisscrossing the chest with an X here, and then a pelvis strap. So what we're doing, if you think about surface area of a strap, we've got one strap with a very small surface area going straight across the chest. When we put that from here to here and here to there, we are exponentially increasing surface area in contact with the body, and therefore we get better immobilization. Now, again, if they're found prone, manually stabilize, and then we roll them. Now, their head's probably going to be off to the side. We're going to gently move their neck into neutral position as well when the body gets rolled. All right, so we're going to roll him to his right shoulder because we don't want to be mashing his face and spinning his neck worse. And onto a board. Now, I said the towel. Pad the voids. If you put somebody on a board, if you feel underneath their lower back, you're going to feel a gap of space between their back and the board. If you don't put something like a towel or a blanket in there, that natural curvature of the spine is going to start to flatten out a little bit, and it's going to create an ungodly amount of back pain for them. At which point they will start to wiggle more and cause more movement of their spine. Now, seated patients generally are in cars. We use our collar. We use this, I'll say the word KED board. Again, KED, Kendrick Extrication Device, was the first one. So we use it kind of like we do the term Band-Aid. KED boards were created for Formula One cars. So when these guys strapped into their seats, they were strapped into this extrication device as well, so that if they got into one of these 200-mile-an-hour crashes, they could literally pull up next to them with a little miniature, like basically a tow truck, hook onto the strap and lift them up and out of the wreckage and set them down. Kind of cool. But it came from that to all of a sudden, well, if it works so well for them, and for 35 years we used them because there were never any studies done on them. And studies that have been done now show them for shit. So here's the KED board. So this goes around the head. This is the back of it, by the way. So this goes around the head. This is a neck pillow, basically, because when you're sitting straight upright in one of these, your head's never in a normal position right against it. So you kind of take up the space. Got 3 color-coded straps. And then these are the leg straps. They go around the legs and hook into here. In the state of New Hampshire, even when we were using the KEDs, these were, for whatever reason, were not authorized to be used, so most services cut them off, so they were out of the way. But that was part of the lifting mechanism for the Formula One guys. These are handles, strap handles, so they could hook into that and just yard them out. All right, so again, I've included this as a little education. So he's sitting up in the car, holding C-spine. We're going to slide this in behind him. We're going to secure the torso first. Now you can see this gap, right? The way our bodies are built are not straight boards like this. That's why we use pillows at night, right? So basically what we're going to do with that other pad is we're going to make a pillow here to keep a normal position. So secure the straps. They're doing the leg straps. I was actually at a registry exam in New Hampshire, and the instructor taught his students to use the leg straps, and the registry was going to fail them for it, or New Hampshire's registry folks were going to fail them for it. So if you use that for whatever reason, don't use those straps. Then we've got the pad here between the KED and his head, and now we're going to crisscross and secure his head. This unfolds, so what I recommend, if you unfold it, you get more surface area, so you get a better stabilization. And secure the hands. And then we're going to spin him in the car. It's very nice. They're using an old convertible to make it easier for him. And then we're going to bring him out onto a board. Now, this standing takedown, the idea behind this is if you move, you're going to be paralyzed and die. And that's horse shit. So we'll talk it over, but we don't do this anymore. I don't know of any of the states that actually do this. But, it could be a question on a test. So hold C-spine, put a collar on them, slide the board in behind them. And then the best way to do this, oh, it looks like you get run over by something. The best way is you reach in with this arm, this hand between his body and his arm, and you grab one of the handles, one of down here, and he does the same thing. And then on the count of 3, by his count, you just go over backwards, and it's scary as hell. The patients hate it. They jerk, they reach. So you've got to really talk them through this while you're doing it. See, you've got their hands in there, gripping on, and then down they go. Because if you try to strap them while you're standing up, all you're going to do is have to maneuver them, remaneuver them, loosen the straps, reposition them, retighten the straps. So it's best just to do it at one time. Now, rapid extrication.
How many times can I run over your strap there? However many times I run over?
As many as you want. Hey, you're the boss, not me.
No.
Oh, I like that. That's a dying art, though. That's the one of the campground hosts here at the campground. He just drove through my frickin' side on a golf cart. Friendly guy, though. Anyways, God. All right, so rapid extrication, we do this. If you think that they're unstable, especially if altered mental status, right? They can't turn, stand up, and sit down on your stretcher. You have to pull them out of the car. Either, but in the old days, if they were stable, we were going to use a headboard and remove them from the car. So if they were critically injured or somebody else was critically injured, we would basically, while trying to hold C-spine and with a collar on, we would try to keep them in line and just turn them, lay them down, and yard them out of the vehicle. Okay. So you can see here, he's got holding C-spine, explaining what's going on. We're going to start to turn him and rotate him. A lot of times it is easiest to take them out head first. However, if they were slumped across the seat, it would certainly be easier to come out either the other door or feet first. Bring the feet up onto the seat and out onto a board we come. Now, I'm not a fan of this, and what I mean by this is we've got one firefighter kind of haphazardly holding the backboard. I prefer to get the stretcher in there at the right elevation and the backboard on the stretcher, so that way I know it's more stable. We're not going to drop the patient because, ooh, we did this great job extricating the patient, and then halfway out, fuck, we dropped him on the ground. So then, boom, out onto the board and out onto the stretcher. And then we secure them from there. Now, helmets. If the helmet fits well, if we can get to their face, so like the half helmets, like you see the state troopers wear, those just take those off. A helmet that has an open face to it. You can leave that on and get to the airway, then leave it on. The issue with helmet removal is a lot of manipulation of the head and neck when you do it, even if you do it right, even if you do it super carefully. So if you can leave it on, and that's football helmets, motorcycle helmets. If football players, if you take a helmet off, you have to take their shoulder pads off too, because if you don't, the head drops back. into this unnatural position. Okay, so helmets, then shoulder pads. All right. I've got a couple of different helmets at home, and we will go over those. I'll bring them in. You guys can practice taking them off me, and I'll show you just some different parts to those. If it doesn't fit well, if the head's moving around inside of it, you know, it's a buddy's helmet, for example, you got to take the helmet off. So EMT1 grabs the face mask portion of the helmet, maintains stabilization. EMT2 removes the chin strap and then grabs the mandible of the patient with one hand and puts his head underneath, his hand underneath, and supports the top of the neck and the bottom of the head with the other. Then EMT1 slowly pulls out and up. Full face helmets are the ones that have the bar coming across the chin, which all the studies show are the best protection. And by the way, if you ride, a study here in Florida that was done about 20 years ago showed that 45% of all motorcycle accidents have facial impacts. So full face helmets are a pretty good idea. So open face or closed face helmets, it works the same way. The only problem with the full face ones are that as you come off the head, you've got to rotate up a little bit to get that chin bar over the nose, or you're going to cause them some pain and agony. Now, football helmets. Most of the time, the coaches have a toolbox, even like midget football, because sometimes pieces get broken and they need to replace them. So a lot of times they'll have a screwdriver in that box so they can change a face mask if they had to, or put a new strap on a helmet, okay, like one of the straps that holds the face mask on. So if not, somebody around us, either us or one of our partners or one of the firefighters, usually has a Gerber or type tool, a multi-tool that's going to have a screwdriver on it. Around the face shield, around that cage that hooks into the helmet, there's anywhere from 4 to 6 screws. Just undo those screws, holding C-spine, undo the screws, and that cage comes off the front. Okay. I don't have any access firsthand with like lacrosse helmets and stuff. My guess is they're pretty similar. Okay. So again, if the helmet's removed, you got to take the shoulder pads off, otherwise that head gets hyperextended. Football helmets, usually, again, if it's an organized football game, the helmets are basically fitted to the patients, to the players. If you're playing backyard football and you've got buddies who are, you know, just sharing helmets, and it may be different. Yeah, I guess if you want to use these things to try to cut those are, no, I'm screwdrivers and remove them. Helmet removal is the same thing though, right? One of the EMTs has a hand on the chin, one has it under the neck, and what you're going to do then is the other one just kind of pulls it apart and slides it off after you've done the clips. Now, I am not transporting any patient at all with a face mask in place. I don't care if it's football, soccer, hockey, don't care, because when that airway goes south, it's too late for me to be messing with it. So that's coming off right after I do my ABCs and my primary assessment. Or while I'm doing those, I'm having somebody else take them off. I did a football injury with a kid, like a junior in high school, helmet to helmet impact. It was described as the two of them were diving for something like a fumble kind of thing. And in midair, body stretched straight out. So they're both like now 12.5 feet long, hit helmet to helmet. both hit the ground. One jumped right back up and went in the huddle. The other kid didn't move, couldn't move. He had a lot of neck pain, temporary loss of consciousness, 10, 15 seconds. A lot of neck pain initially, and so I'm doing an intercept. By the time I get out to them, he's gone from having a lot of neck pain to being paralyzed from his, he started with this sensation of numbness and tingling, and then of not being able to move from his head down to his feet in that order. Kept breathing though. And when I got in the truck, they had done a great job of mobilizing him. He was still in his pads, still fully friggin' clothed, and had his helmet and face mask on. And now was starting to reverse that process. So like he was starting to move and feel his fingers and toes, and then up the torso or his toes, and then his legs, and then gradually over about 10 minutes, he had all movement back. He could talk to me, knew everything was going on. First thing I want, get that frickin' face mask off him, right? And then cut everything off. Head to toe, get him naked, leave his shoulder pads in place because his helmet's on. I'm fine with that. We've got a helicopter coming in, and but now he's awake, alert, oriented, moving everything. So I called my ER doc and said, this is what's going on. What do you think? And this young ER trained, EMS trained ER doc on the phone said, do not bring him to me. This was at Frisbee. Do not bring him here to me. I said, okay. He goes, put him in the helicopter. I'll let you, when we get back, we'll talk. I said, okay, cool. So the helicopter shows up. I explained everything, put him in the helicopter, went back to the ER, and the doc described spinal shock to me. I mean, I knew about this stuff, mind you, but I didn't think of it in this kind of setting. He said that these kids die that first night at an alarming rate. They go to a local ER. The ER does a CAT scan. Nope, everything looks great. There's no fractures. He can go home. That night, that swelling starts to occur in the cord. Right, we know he had spinal shock from that. Right, we know he had a spinal concussion event, significant one, and then it resolved. And that night, it swells up, affects his cord. His diaphragm shuts down, and he dies in his sleep. He said it's an amazingly high percentage of these events. So they need to go somewhere like a level 1 trauma center where they know this shit, or a level 2 with a good neuro center like Portsmouth has. And they watch them overnight. They do a couple of extra MRIs, like, you know, they do a CAT scan and an MRI. And then a few hours later, they do another MRI. And then, if something happens, then boom, they're in the hospital. They can be intubated, ventilated, whatever they need to be for the time frame that it takes the swelling to go back down. So that was an eye opener for me. So removing the helmet, same as with other helmets. If you need access to the chest on any of these shoulder pad things, there are straps. There's either strings. I mean, I know when I played football, they were like a big shoelace that held the chest together. So shoelaces or Velcro or some sort of strap. You can cut those or untie them, pull them apart to get to the chest if you have to. As far as immobilizing infants and kids, it's the same process in a squirming, screaming child that wants nothing at all to do with what you want to do. So yeah, good luck. Good luck with that. It's tough. Now you can immobilize them in their car seat if you want. Horse collar kind of thing. So you take a blanket, you roll it up, and you can kind of put it around their head to help provide some extra support. Little kids do not fit in adult size collars and boards. They should have pediatric size equipment. So that is chapter 40 of the AEMT curriculum, which is spine injuries. normally I almost said, oh, do you guys have any questions? Forgetting about the fact that we are not live right now. So anyways, that's the first chapter on spine and injuries. I'm going to do the chapter, what is it, 28 or 29? I think it's 29 on the EMT one as well. So I will send links out to these, and I'm going to end up also, hopefully this week, I'm going to put a bunch of these up on my YouTube channel so that you can refer back to them easier as well. All right, well, from sunny, warm Florida, take care.